That was terrific. We'll have a chance to talk about these. We've had two wonderful talks. We're going to move ahead, and then we'll have discussion about this debate. So the next presenter is Dr. Whitlock, who's going to talk to us about, who's from McMaster in Canada, who's going to talk to us about a new, ongoing, now randomized trial from the surgical approach for left atrial appendage ablation or exclusion. Richard.
Perfect. Oh, thanks. Okay. Well, thanks a lot for the invite, and really it's a perfect debate to follow. I was asked to give a talk on implications of surgical LAA ablation or exclusion, implications on rhythm control, and really that talk would be short because we really don't know. So I'll move on to my conflicts. I really have none to declare. I have no financial interest in any way in any device or drug. But I have to say I'm a heart surgeon and I'm really interested in LAA exclusion. Do I hope it's going to work? Yes. Do I think it's going to work? Yes. Do we have the evidence that it prevents stroke? Not yet. I echo Dr. Holmes's point. We have one RCT as of yet that's well done. But there's few events, and the evidence simply is not there. So today I'm going to talk a bit about the left atrial appendage, its implications in AF, its implications in stroke. But then I'm going to present a trial that we've started, and this has been actually years of work for me. I decided when I completed residency as a staff, I'd take on my PhD. So I just completed my PhD, and I have a bunch of papers coming out on this topic. But we'll start off with left atrial appendage. Actually, let's start off with eliminating AF. So why do we do it? Well, currently, these are hypothetical reasons. It's an improvement in quality of life for patients coming into the ER with symptomatic arrhythmia. There's a potential for reduction in stroke risk, but this has not been demonstrated as of yet. There's a potential decreased risk of heart failure if we get rid of this rhythm. And further, there's a potential for improved survival. But as stated, really, none of these, except quality of life, have been proven. In fact, if you look at the HRS guidelines, this is what it states. They recommend ablation for symptomatic AF. There is no recommendation or no evidence as of yet that it conclusively avoids stroke. So the left atrial appendage, we've been through this many times, and in fact, you'll see much of the evidence in many of the slides are repeat, and again, it's an indication that the evidence in this area is lacking. It's a 2 to 4 centimeter tubular structure attached to the left atrium. We've seen it many times. A few important things is that it's a common non-pulmonary vein site for atrial fibrillation initiation, and Dr. DiBiase in his talk alluded to this earlier, and they've got a great publication on this. In atrial fibrillation, atrial stretch and dilatation promotes stasis and thrombus formation. The left atrial appendage is a remnant of the embryonic left atrium. It's basically formed by the absorption of primordial pulmonary veins in the 4th week of embryonic development. So this is why it was a plausible site for initiation and propagation of AF, and again, proved to be so in Dr. DiBiase's paper. It has reservoir function with high concentrations of atrial natriuretic peptide. So removing this reservoir, what are the implications? We really don't know. Its clinical and hemodynamic role are poorly understood. So this is a diagram taken from Dr. DiBiase's work, basically showing the left atrial appendage again in about 935 patients that had failed primary ablation who are coming back. They found in about 27% of those patients, the left atrial appendage was a site of initiation and propagation in these failures. So, so the implication of this is that if we do treat the left atrial appendage, it's probable that we'll increase the success rate of ablation. So, and again, this isn't just through a catheter ablation. There's been papers on placement of the AtriClip to mechanically exclude the appendage, and also is effective in reducing atrial tachycardias. So let's talk about atrial fibrillation and stroke. So there's three main approaches to stroke prevention in atrial fibrillation patients. The first, prevention of clot formation by medical therapy. There is no question, you cannot argue that this doesn't work. So it's a very effective therapy. There have been tens of thousands of patients, just as we saw earlier, 50,000 patients for the novel anticoagulants randomized against warfarin. It works. Warfarin works also. However, it's limited by serious bleeding problems. There's a problem with continuity of treatment. There's underprescription. There's noncompliance. There's suboptimal anticoagulation control. Even if you're on the drug, your time in therapeutic range is usually about 65 to 70%. That's in trials. And there's also treatment withdrawal. Second approach, elimination of AF itself. Well, we've seen so chemical cardioversion as well as catheter-based cardioversions, they've never been shown to suppress all episodes of AF, and they've never been shown to prevent stroke. Lastly, what we're interested in is physical elimination of the left atrial appendage. The results from the trials are encouraging. There's a first proof of concept in PROTECT AF, but it's not definitive. So the rationale of left atrial appendage exclusion, AF, and stroke, well, we know in AF, 70% of the strokes are cardioembolic, and at least based on echocardiographic studies, 90% of the clots in AF form in the left atrial appendage. So this is a picture of a left atrial appendage that I took off during my case. This obviously is not the same patient. This is actually patient number 2 from the LAA-2 trial, which is a pilot study of left atrial appendage occlusion and surgery, who did not have their left atrial appendage occluded, had a bout of atrial fibrillation, short-lived, and this was the result. This is obviously inconsistent with good quality of life, as well as life alone. So why is left atrial appendage occlusion not standard practice? Greg won't like this. I put the cardiac surgeon on the other side, even though I'm a cardiac surgeon. So clinically, I agree with his diagram. Evidence-based, this is where it stands. So 1949 was the first description of left atrial appendage exclusion in JAMA by a surgeon. I cannot believe in 60 years we have not been able to generate the evidence to demonstrate that this is an effective strategy in stroke prevention. That's why I put us down here. I'm kind of disappointed. Interventional cardiologists and the EP with their catheters, see here, a little catheter there. They're further ahead. I mean, again, this is controversial, but the cart was put before the horse here. We had an open chest, the atrial appendage right there. Why didn't we generate proof of concept in surgical patients and then move to intravascular devices? Cardiac surgery failed in this. Thrombologist is way ahead of us. So, this is John Eichelboom, my colleague, who's a great guy, but, striding confidently, because he's got the evidence of antithrombotics. And patients may not like antithrombotics, but they work. So there is insufficient evidence for efficacy of occlusion procedures. There are now good alternatives to warfarin with powerful data supporting safety and efficacy. We need more high-quality research on LAA amputation or exclusion. So these are approaches to occlusion. We've seen this in many slides from prior presenters. The surgical side, amputation and closure from within, which I do not like. Suture ligation, stapler, other device, percutaneous devices that are now being studied with upcoming Prevail. I think that'll be very exciting. But the point is, one randomized trial well done comparing LAA occlusion to device to warfarin. And that was PROTECT. I don't think I have to go over the results again, but just to highlight, so total stroke, right here, this is original paper, 28 events. So we just don't have enough events in this literature yet to claim non-inferiority and to claim superiority, but it's very promising. For these devices versus drug comparisons, again, as we do move forward and the literature comes out, we obviously will always have to manage the higher upfront risk. This is surgery versus medical therapy pretty much in any field, the risk of acute complications, as well as the numerically lower but continual risk of drug therapy long term. So cardiac surgery, again, this isn't really an ideal environment to study this. So we look at the left atrial appendage. Every case, it's in our face. It's exposed, it's readily accessible. It only takes a few minutes to amputate these things properly. The surgeon has to be invested. They can't be getting paid $1,000 to take off the tip of the atrial appendage. So billing fees can't come before evidence, and that's a problem in many countries. So it takes a few minutes, takes about 7 minutes, equivalent to a distal coronary anastomosis. We hypothesize that LAA occlusion will reduce stroke and will benefit virtually all AF patients at the time of routine cardiac surgery. We've gone over this. It is our bias, our group's bias, and the bias of many surgeons that the way to do this is to excise or amputate and suture close the left atrial appendage. If you cut this open, visualize tuberculations, cut right down to smooth atrium, and it's often right onto the pulmonary vein, and you do a linear closure, it's very effective. But with any therapy or any procedure, you can get individuals who are less interested and they don't do a great job. So generating the evidence. So there's a few exciting things on the horizon. So the question was, what's the impact of LAA isolation or ablation or occlusion on AF rhythm control? Well, BELIEF trial is having a look at that. So LAA isolation on long-term procedure outcomes in patients undergoing ablation, patients with persistent or long-standing persistent atrial fibrillation. And LAAS-3, which I'll tell you about now, will demonstrate the benefit of surgical LAA exclusion on stroke and non-CNS emboli in cardiac surgical patients. So this is a trial that was funded actually 2 months ago. So this is called LAAS-3, Left Atrial Appendage Occlusion Study 3 because there was 1 and 2, all pilots, to figure out how to best do this. This is a multi-center international RCT of left atrial appendage occlusion versus no occlusion in adult AF patients with CHADS VAS greater than 2 or more, or greater than equal to 2. Patients will be randomly allocated to occlusion or no occlusion on top of usual care, and I'll show you why we think we'll see signal. It follows intention to treat. There will be 4,700 patients in this trial in 60 centers. The rationale of on top. Coumadin suffers from patient noncompliance. It's a problem with all chronic medications. And you've seen this slide before, but basically at 4 years, you've got about 50% of people who are prescribed Coumadin still on Coumadin. There's a physician reluctance to prescribe Coumadin. So if you look at our Medicare data, if you enter into eMERGE with high CHADS AF, 50% chance you'll actually be prescribed Coumadin. There's a frequent need for discontinuation for surgery, procedures, and diagnostic tests. And lastly, and this question's been raised, is it ethical to withhold a proven therapy at this stage of the evidence in this population when they're already undergoing a concomitant procedure? So primary objective of this is to look at stroke or systemic embolic events over duration of follow-up, which is mean 4 years. Secondary objectives is mortality, operative safety outcomes, incidence of rehospitalization or for heart failure. When I talked to my Chinese sites about this study, so West China Hospital, 7,000 hearts a year, I asked them would they be willing to leave the atrial appendage on when they do their maze or ablation. They said, absolutely, we always do. We stopped taking the left atrial appendage off for fear of heart failure. So it's very interesting to see biases around the world. So this is an important outcome that we're tracking. Incidence of bleeding, MI, with the circ being right there, impact of LAA occlusion on AF ablation procedures. The inclusion criteria: adult patients on pump procedure, CHADS VAS greater than or equal to 2, and informed consent. They obviously have to have AF. We are excluding off-pump surgery in this first large trial, mechanical valve implants, heart transplants, complex congenital surgery, and redos. Furthermore, if they've had previous placement of a percutaneous device, they're also excluded. The intervention, we are currently allowing 2 ways of closing: amputation and closure, which we're promoting as the #1 way to do this in this trial, or stapler. We will assess devices as people request, but the trial will not be paying for the device. Sample size calculation, so we will have 80% power to look at the 25% risk reduction with our 4,700 patients. So these are the statistical assumptions, and distribution, what we feel people will be on in terms of their antithrombotics. In brackets here, we looked at our first 63 patients randomized within LAAS-3 globally. These are the actual numbers. So 5% of people, or 7.7% in reality, are not on anything. 30% of elevated CHADS VAS patients with AF are on aspirin alone, and roughly 60% are on some sort of OAC. With this, we derived our expected event rates, our expected relative risk reduction, and this is how we came up with our sample size. So the established national leaders, David Taggart in the U.S., Dan Sessler's involved, in the U.K., in the U.S., Marco Eilings in the Netherlands, and a whole group of people that have been involved in our network of cardiac surgical trials already. So this is LAOS 3 and our projected, so we're doing extremely well. We're above our expected recruitment curve. We're just about to hit 100 patients, and that's pretty good in a few months. We have an established network, so we just randomized nearly our 6,000th patient into my other trial called SIRS, it's steroids in cardiac surgery. We have 78 centers globally participating in that. We've published our coronary trial, which randomized 4,700 patients in 110 sites, roughly. This was the largest trial in cardiac surgery. This is now the largest trial in cardiac surgery, the SIRS trial. So we have a great network to do this. So the primary justification for AF ablation is the presence of symptomatic AF, improving quality of life. We think that LAA ablation exclusion may increase the likelihood of success of ablation. The discontinuation of systemic anticoagulation post-ablation is not recommended by HRS. We feel that LAA ablation exclusion may reduce the risk of stroke in AF, and therefore, in the future, may eliminate the need for anticoagulation on top of ablation procedure. This is the information. I would promote that you chat with your surgeons or your research teams about participating in LAOS 3. It would be great to have some more U.S. sites. So take down my email address, happy to chat. Take down the study email address, but communicate with us and get involved. Thanks a lot.
That was great. We look forward to seeing that trial as it continues to evolve.